The pericardium is a double-layered sac surrounding the heart. It consists of a visceral serous layer and a parietal fibrous layer. Normal pericardial fluid ranges from 15 to 50 milliliters. This fluid acts as an ultrafiltrate of plasma and reduces friction. The pericardium prevents sudden dilation of the right atrium and right ventricle. It also stabilizes the anatomical position of the heart within the thorax. It limits spread of infection from adjacent lungs and pleura. Complete absence of pericardium is usually asymptomatic. Partial defects may lead to herniation and sudden death. Acute pericarditis is the most common pericardial disease. Chest pain is the hallmark presenting symptom. Pain is severe, retrosternal, or left precordial in location. It may radiate to the neck, shoulders, or arms. The pain is often pleuritic and worsens with inspiration or coughing. It is intensified in the supine position. It is relieved by sitting up and leaning forward. Pain may be absent in slow-onset etiologies such as tuberculosis or uremia. Acute pericarditis can mimic acute myocardial infarction. A pericardial friction rub is heard in approximately 85% of patients. It is a rasping or scratching sound best heard at end expiration. It is best detected with the patient upright and leaning forward. Electrocardiogram changes evolve through 4 stages. Stage 1 shows diffuse concave ST elevation with PR depression. Stage 2 shows normalization of the ST segment. Stage 3 shows T wave inversion. Stage 4 shows return to normal electrocardiogram. Mild elevation of troponin or creatine kinase myocardial band may occur. Pericardial effusion commonly accompanies acute pericarditis. Large effusions may cause electrical alternans or cardiac tamponade. Chest X-ray may show a water bottle-shaped cardiac silhouette. Ewart sign presents as dullness at the left lung base. Echocardiography is the first-line diagnostic modality. It is non-invasive and can be performed at bedside. Computed tomography and magnetic resonance imaging are useful for complex cases. They help detect loculated effusions, thickening, and masses. Acute idiopathic pericarditis is often viral in origin. Common viruses include Coxsackie, influenza, and echovirus. Patients present with fever and chest pain 10 to 12 days after infection. Pericardial effusion may occur, but tamponade is rare. Recurrence occurs in approximately 25% of patients. Treatment begins with bed rest and anti-inflammatory therapy. Aspirin is given at 2 to 4 grams per day. Ibuprofen is given at 600 to 800 milligrams 3 times daily. Indomethacin is given at 25 to 50 milligrams 3 times daily. Gastric protection with proton pump inhibitors such as omeprazole is recommended. Colchicine is given at 0.5 milligrams once or twice daily for 3 months. Corticosteroids are reserved for refractory cases. Prednisone is given at 1 milligram per kilogram per day. Steroids should be tapered after 2 to 4 days of response. Anticoagulants should generally be avoided. Refractory recurrent cases may require azathioprine or anakinra. Pericardial stripping is rarely required in chronic severe cases. Hospitalization is indicated in high-risk patients. Risk factors include fever above 38 degrees Celsius and large effusion. Differentials include acute myocardial infarction and connective tissue diseases. Other causes include uremia, neoplasm, infection, and drug-induced lupus. Clinical takeaway is that acute pericarditis presents with positional chest pain, friction rub, and staged electrocardiogram changes.